So seeing that it's 12:01, maybe we'll get started. We have a lot to cover today, so I'm going to dive right in. I just want to take a moment to welcome everyone to the British Columbia Regional Roundtable on Flexible Models of Care for the Clinical Management of Opioid Use Disorder. And I'd like to start by acknowledging with gratitude that I'm joining from the traditional, ancestral, and unceded territories of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh nations. This is a provincial session, so I'd also like to acknowledge the many traditional and ancestral lands across what is now colonially known as British Columbia that have been cared by Indigenous folks since time immemorial. And this is an especially important point to reflect on, given our session today, as we know the harms associated with opioid use and other substance use disproportionately impact Indigenous peoples and communities. So I invite you to take a moment and reflect on where you're joining from today. My name is Sam Robinson, and it's my pleasure to be moderating today's session. I'm a registered nurse and senior consultant working with ChangeMark Research and Evaluation. I also support several provincial initiatives focused on clinical education and workforce capacity building to improve services for people with complex mental health and substance use needs. I'm also an adjunct professor with the School of Nursing at UBC. So today we have an amazing lineup of speakers and panelists, many of whom I've had the pleasure of working with over the years, and I know you're all in for a productive and thought-provoking session. So today's session is primarily focused for clinicians and really will challenge us to think creatively about how to provide better opioid use disorder care, and specifically how we can use flexible approaches to improve treatment retention and ultimately outcomes for people with opioid use disorder. This webinar is part of a suite of knowledge translation activities for the OPTIMA trial, all of which focus on expanding flexible models of care. So there's several different events aimed at communicating the trial's findings, both for community and clinical settings. And in addition to regional roundtables like this one today, we'll also be hosting community workshops where we'll present the findings to people with lived and living experience and other community partners. We also have plans underway to host a national panel discussion. So several different activities coming your way. We really appreciate you joining us today. So for our agenda today, we'll start with a brief presentation on the OPTIMA trial itself and some key findings, followed by a few minutes for Q&A. So think about your questions as we hear the talk. The second part of our session will be a panel with an opportunity to take audience questions for about the last 10 minutes of the session. So some housekeeping items. Please keep your camera and microphone off during the session. The session will be recorded, and the link to the recording will be shared after the event. If you want to review, or if you have to leave early, we'll send it out afterwards. Please enter your questions into the chat box. We'll be taking a look throughout the session, and we'll try to get to as many as we can. Also, several of the panelists and myself can stay after one for about 5 to 10 minutes. So if you do have a burning question that we're not able to get to, please feel free to stay on the line, and we can kind of keep diving in for 5 or 10 minutes after one. As I mentioned already, we really encourage you to complete the pre and post-session surveys. So the pre-session survey you'll find in the calendar invite that was sent to you and how you actually entered this session. And then we'll be sending out a post-session evaluation survey after the talk. And we have 2 $50 gift cards up for grabs. And so we'll do a draw for that following the session. And just really appreciate your feedback as it helps us to improve upon future sessions and events. So it's now my pleasure to introduce Dr. Eugenia Socias for a presentation on the OPTIMA trial and its findings. So Dr. Socias is a research scientist and the clinical research program lead at the BC Centre on Substance Use. She's also an assistant professor in the Division of Social Medicine, Department of Medicine at the University of British Columbia. With a background in infectious diseases and addiction medicine, Dr. Socias's research interests focus on health services and clinical research in substance use, HIV, hepatitis C, particularly as they relate to the optimization of healthcare delivery. She has over 10 years of experience in conducting observational and interventional research in HIV, hepatitis C, and addiction medicine, and with vulnerable populations. Dr. Socias is also the RPI for the BC node of the OPTIMA study. And now I will turn it over to you, Dr. Socias.
Oh, yeah. Can everyone see my screen, Sam? Yeah, okay. Thanks for that introduction, Sam. And good morning, everyone. As Sam mentioned, over the next few minutes, I will give you a very brief overview of OPTIMA's rationale and many findings that hopefully will help inform our discussion on how we can optimize OUD care to make it more flexible and more patient-centered care. This is my disclosure slide. So in terms of background, and as I'm sure all of you are aware, due to their multiple individual and public health benefits, including protective effects on mortality, opioid agonist therapies remain the standard of care for opioid use disorder, including for people using prescription-type opioids. We are lucky in BC to have a number of pharmacotherapies that we can use to treat opioid disorder, being the most common ones methadone and buprenorphine naloxone, which are also the focus of the OPTIMA trial. As you would also know, given differences in their safety profile, the way these two medications are dispensed in community settings is very different. With methadone, typically require supervised dosing, at least for a period of time, given its higher risk of respiratory depression and fatal overdose. In contrast, given its lower risk of overdose and diversion, it is possible to provide buprenorphine naloxone under a more flexible take-home dosing model that could potentially help support patient autonomy. And the difference in mode of care is not trivial, as among the multiple barriers to access and retention to OAT, one significant barrier relates to restricted take-home dosing policies, particularly in the case of methadone. Another point that I wanted to bring up is that despite the growing synthetic opioid epidemic, there is very limited evidence-based data to guide the management of individuals with prescription-type opioid use disorder. Indeed, most clinical trials comparing buprenorphine and methadone have been conducted among people using heroin and using similarly strict dosing schedules, which doesn't account how these two medications are actually delivered in the real world. This is a critical research gap. As discussed before, supervised dosing is one of the main barriers to OAT retention. As such, OPTIMA sought to address these research gaps and compare the effectiveness and safety of two models of OAT for the treatment of prescription-type opioid use disorder in real-life clinical practice settings in Canada. In terms of study design, OPTIMA was a two-arm, 24-week, open-label, multi-center, pragmatic, randomized clinical trial, with the primary hypothesis being that flexible take-home dosing buprenorphine would be non-inferior to supervised methadone in suppressing illicit opioid use through the duration of the trial. Participant recruitment for the trial took place between October 2017 and March 2020 in 7 sites across 4 Canadian provinces. And as you can see on the map, BC had 2 sites, both located in Vancouver, the Rapid Access Addiction Clinic in St. Paul's Hospital, and the Columbia Street Primary Care Clinic run by the Portland Hotel Society. Regarding the interventions, both OATs were prescribed following Canadian OAT guidelines and product monograph, which you can see summarized on the table on the bottom of the slide. In terms of take-home doses, which was the main aspect that this trial was evaluating, for buprenorphine, in line with product monograph, this was allowed once the patient was deemed clinically stable. Although there was some flexibility as to when to start carries as per the addiction doctor discretion, study physicians were encouraged to start offering carries within the first 2 weeks of treatment initiation. In the case of methadone, as mentioned, we follow Canadian guidelines, which typically recommend to wait 2 to 3 months before starting to provide progressive take-home doses. On this slide, you can see a non-exhaustive list of eligibility criteria. In brief, we included treatment-seeking adults with an opioid use disorder related to prescription-type opioids, and here we included both licit or illicit opioid analgesics and fentanyl, who were clinically stable and did not have a pain condition that required opioids. We also excluded people who were on OAT or reported using heroin as the most frequent opioid in the prior 30 days, as well as women who were pregnant or breastfeeding, as the Canadian product monograph for buprenorphine naloxone at the moment listed pregnancy as a contraindication for buprenorphine naloxone use. Moving to the actual findings of the study, as you can see on the left, in total, 272 participants were eligible and randomized to one of the two study arms. And as you can see, our sample predominantly consisted of middle-aged men. This figure and tables here summarize how interventions were implemented. And as you can see, roughly speaking, both methadone and buprenorphine were prescribed according to clinical guidelines, both in terms of recommended dosage and timing and frequency of take-home doses. Specifically for take-home doses, as expected, there were significantly more participants in the buprenorphine arm, around 3/4, versus around 1/3 in the methadone arm that were prescribed take-home doses. And these were prescribed earlier in the course of treatment for buprenorphine within 2 weeks, versus almost 3 months for those people on methadone. Another aspect that I would like to highlight here is that OPTIMA was a pragmatic study. So participants were allowed to switch medications during the course of the trial based on a shared decision-making process between the clinicians and the patients if clinically indicated. And indeed, switching was a relatively common phenomenon in the trial. Specifically, over a fifth of participants in the buprenorphine arm switched to another OET during the course of the study, which is almost double the rate than the people in the methadone arm. Regarding the primary outcome, as you can see on the left, the proportion of opioid-free urine drug screens in the buprenorphine and methadone arms were 24% and 18.5% respectively, resulted in an adjusted mean difference between the two arms of 5.6% in favor of buprenorphine, which not only demonstrated non-inferiority of buprenorphine, but also suggested that buprenorphine may actually be associated with higher effectiveness in suppressing opioid use compared to methadone. In terms of retention, as you can see on this table, retention rates were overall low, with only around 1/4 of participants in the buprenorphine arm being still on this medication and 24 weeks versus 1/3 in the methadone arm, which reached statistical significance in favor of methadone. However, if you remember, participants were allowed to switch medications over the course of the trial. So when retention in any OET was considered, rates increased in both arms, particularly in the buprenorphine arm, and we no longer saw statistical significant differences in retention between the two groups. Another important finding of the study is that both medications were overall safe, with only 24 drug-related adverse events, mostly mild and moderate in nature, and with no significant differences between arms. The most common drug-related adverse events were withdrawal symptoms, overdose, and hypogonadisms, which is expected given the toxicity profile of methadone and buprenorphine. Looking at patient-reported outcomes from the analysis conducted so far by investigators from the CRISM network, we can say that overall use of both buprenorphine and methadone led to improvements in most of them, including in quality of life, cravings, depressive symptoms, patient satisfaction, and pain, with some slight differences in effectiveness between medications, particularly for craving, where buprenorphine performed better, and pain intensity, pain severity, where methadone seemed to have done better. As shown in the last row of the table, the one domain where we did see some significant differences between arms was in sexual functioning, where methadone was associated with worse outcomes, particularly in women, while buprenorphine was associated with improvements. And so what are the implications of OPTIMA findings for clinical practice? First, results of the OPTIMA trial indicating that the safety and non-inferiority of flexible take-home dosing buprenorphine versus supervised methadone in suppressing opioid use, with decreased retention in the assigned treatment, but similar retention in any OET, confirms recommendation of the BC and Canadian OUD guidelines, now in the context of prescription type opioids. included for early take-home doses for buprenorphine, and the benefits of step care approaches. Specifically, while both methadone and buprenorphine could be considered appropriate initial treatment options for people with prescription type of use disorder, it could be argued that given buprenorphine better safety and tolerability profile, together with its more convenient model of care, it should maybe be offered as a first-line agent as long as streamlined transitions to other OATs are available if clinically indicated. Given that at the end of the day, what matters is whether people are retaining treatment and not so much the treatment they are in. The OPTIMA trial also underscores us how difficult it is to treat people with prescription type of use disorder, and that sadly achieving optimal outcomes in real-life settings may not always be possible. This in turn highlights the need for proactive discussions between clinicians and patients with OUD on how to make their treatment more patient-centered more patient-centered based on their individual needs, as well as the need for more research to identify adjunct interventions or alternative models of care to make OAT more accessible and more acceptable to improve outcomes. I would like to end by thanking everyone who made the study possible, in particular the participants of the trial, research staff, study clinicians across all nodes, as well as my co-PIs here in BC and other nodes, our funders, CHR, and the CRISM network. Thank you very much, and I'll be happy to take any questions that you may have if time allows.
Great, thanks so much, Eugenia, and really appreciate that great presentation, and also just a really nice overview of the trial and its findings. We'll now open it up to the audience. If anyone has a question for Eugenia, we have a couple minutes and can take a couple questions. So we'll just monitor the chat. Feel free to put your question in the chat and we can get to it. Maybe while folks are thinking about some questions, I have a question. I was just curious, at the end of the presentation, Eugenia, you mentioned the importance of conversations between healthcare providers, prescribers, and their patients, and really looking toward individualized approaches to treatment that are going to meet people's needs. And I'm just curious, how you think we could do that. You mentioned making OAT kind of more acceptable and more accessible. And I see that, from the findings, both medications seem to have similar improvements and outcomes. So I just was curious if you had some ideas around that piece.
Well, I don't want to spoil the rest of the panel discussion, but I think the key is to have options like that, not just that one model that fits all, but actually have options and offer those to the patients, and then based on shared decision, try to see what would fit better for one particular patient or the other. Also taking into account that maybe the medication we start today may not be the one that they will keep taking for the rest of their treatment. Just being open to those changes and to those conversations, as we do in other for other chronic diseases.
Yeah, absolutely. Thank you. Well, not seeing any other questions or comments, maybe I'll move us now into our panel discussion, and certainly people can keep percolating on the presentation and the OPTIMA trial and its findings, and maybe to start thinking about some questions you might have for our panel around kind of flexible models of care and thinking about how we can improve opioid use disorder treatments. So it's now my pleasure to introduce our panelists. I'll invite all of you to turn on your cameras. And I'd welcome each of you now to kind of share a bit about yourself. So maybe your name, your role, and the lens that you bring to your work. So I'll start with Dr. Alana Hirsh.
Hi, thank you very much for having me. And Eugenia, thanks for your presentation and just all the work you've done in this field. My name is Alana Hirsh. I'm a UBC clinical assistant professor and a family physician at a clinic called Kilala Lelam, which is an urban indigenous health and healing cooperative in the downtown east side, and I also work at the Drinkers Lounge, which is run by PHS. And the lens I bring is as a cisgendered settler on the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh people, and as a doctor who has worked extensively and primarily with a complex population who manage the challenges of addiction, mental health, poverty, housing instability, and lots of trauma. And yeah, thank you. Happy to be here.
Great, thank you so much. Now I'll invite Dr. Paxton Bach to introduce yourself.
Thanks, Sam. And thanks, Eugenia, for that presentation and for all of the considerable work that went into this. Hi, everyone. My name is Paxton Bach. I'm a physician. I'm an internist by training and an addiction medicine physician at St. Paul's Hospital in downtown Vancouver, and additionally a research scientist with the BC Centre on Substance Use. And I'm very happy to be here to talk about the results of this trial and clinical practice today. I suppose that the lens that I bring, or sort of the unique lens that I can bring is that of my training as an internist and as a researcher, and really being excited about the ongoing evolution of the specialty in terms of really developing an evidence base and practicing according to the best available evidence that we have, and really critically appraising these studies, which are thankfully starting to come more and more often, and seeing how we can apply this knowledge to our day-to-day practice, while recognizing that every patient we see is unique in their goals, and that understanding that flexibility is always critical.
Great, thank you so much. Now I'll turn it over to Dr. Patricia Caddy for your introduction.
Hi, can you hear me? Perfect.
Oh, we did hear you, and now we can't hear you.
How about now?
Yep.
Okay, great. I'm Dr. Patricia Caddy. I'm an addiction medicine physician and family doctor working in a mid-sized city, so working in Nanaimo on Vancouver Island. The lens that I bring to this discussion, I guess, is, I have the pleasure of working in the community that I grew up in. I grew up in a low-income setting here in Nanaimo, and I feel very privileged to be able to come back and serve the community that I was raised in. So excited to contribute to the discussion today.
Great, thank you so much. Really happy to have you here. Next, I'll move over to Emma Garrod.
Hi, thanks. Sorry, I'm joining from my phone, so it's like a little bit trickier to navigate. My name's Emma Garrod. I am a registered nurse. I have mixed settler background working on the unceded Coast Salish lands here. I am newly on day 3 of being in a clinical nurse specialist role with First Nations Health Authority, and also co-direct the addiction nursing fellowship at the BC Centre on Substance Use. My lens brings 15 years of clinical work in a number of different settings: outreach, primary care, emergency departments, and inpatient, and have worked with a number of clients over the years, many who, have struggled to sort of meet their needs in a system of care that has been relatively unflexible, and we're just starting to have more flexibility now. So just a long period of inflexibility, and I think that contributes a lot to the stigma around substance use and some of these treatments too, and people's willingness to try them. And my new lens, I'm thinking a lot about care in rural and remote settings. So thanks so much for having me, and thanks everyone for joining us today.
Great, thanks, Emma. Now I'll turn it over to Mona Kwong.
Hi, everybody. I'm Mona, a community-based pharmacist working in practice, actually in a smaller pharmacy for over 20 years already. Also with BCCSU as the pharmacy advisor role, and director of the pharmacy stream of the Interdisciplinary Addictions Fellowship Program. So the lens I bring, it's been a long journey. I mean, I've worked in this area for over 20 years, starting with HIV and then progressively moving into this space, and really to be a better advocate as we learn more in general in this field as it progresses, like what Emma said, like what Eugenia said, and everybody has said, and hopefully we can do better in this field as we progress.
Great, thank you, Mona. Just a note that I know Zach Matieschyn was planning on joining us, but had a family emergency at the last minute, so sends his regrets. But I'm really pleased to have all of you here on the panel, so many different disciplines and perspectives, and just such a wealth of both experiential knowledge and different types of practice in different types of settings and with all kinds of folks. So really, really looking forward to jumping into our panel questions. And so one of the key findings from the OPTIMA trial was that take-home buprenorphine naloxone was non-inferior to traditional treatment with methadone with observed dosing, and that more broadly, flexible models of care can improve treatment outcomes. So I'd like to start by kicking off the panel with a bit of a broad question to all of the panelists around flexibility. So when we talk about flexibility, or we think about flexibility in the care of individuals with opioid use disorder, I'm curious for each of you what comes to mind. Maybe I'll start with Paxton.
Sure, thanks, Sam. I guess I'll start by saying that I find the results of this trial really interesting and truthfully pretty in keeping with my clinical experience. There's nothing here that was tremendously surprising to me in terms of no one form being particularly superior than any other form, and overall just making note of poor retention in general, which I think echoes what we often are seeing in practice these days. And so I think that flexibility piece is a really critical part of this discussion, because we know we have ample data talking about the lack of flexibility in our prescribing, in the means of prescribing, as well as in our system as a whole, is a major contributor to that poor retention. And so this study really, I think, kind of validates a lot of my experiences in terms of really encouraging me to be flexible with my patients in not specifically recommending one form of OAT over another, but really talking to them, describing what their different options are looking like, the various characteristics and idiosyncrasies of the different options that we can provide, exploring their goals and really trying to come up with a customized plan for an individual patient. So I think flexibility really is a key part of that individual discussion as well, and it also drives home for me that broader discussion around the lack of flexibility in our system as a whole, and the need to really try as hard as we can to address that at every level, to build a system that is more patient-centered and really speaks to those needs that have been articulated over and over and over again by our patients around the rigidity and challenges in navigating our current system and how we can do better.
Great, thank you. Yeah, I think that's so important. And as we think about flexibility, just as you said, and I think Emma touched on this in her intro as well, was just the system that in and of itself is lacking in flexibility, and something that sounds like if you're finding in your practice, increasing opportunities for kind of patient-directed goal setting and creating that customized plan has really worked and is really beneficial. I'm wondering, Mona, from a kind of pharmacy perspective, what thinking about flexibility in opioid use disorder care kind of means to you in your work?
The same thing as Paxton and Emma and everybody, as it's mentioned, is really like when we're looking at our patients and patient-centered, going through, the many different years, and especially the last 2 years with COVID, that there needs to be more of a flexibility, and changing our inflexible thoughts was something that's really tangible right now with this study. So it really, I guess, echoes with me that at least there's something to fall back on, saying, yeah, things are moving along the right direction for patients and meeting them at their goals and in their environment. So it's really nice to see this.
Thank you. Any other thoughts on kind of broad flexibility and what it means in your practice from any of our other panelists that want to jump in?
Sure, I can speak to that. Yeah, echoing what other people have said. And also, I think flexibility is of additional importance right now, because I think the context has changed so much, and the model of treatment that we're operating in is one that was set up based on evidence. I mean, based on studies that were done on when there was a different drug that was being primarily used on the street, and different overdose rates. And so, I think it's so important to be flexible right now and really mindful of the fact that we're operating in a really unique time where we have limited evidence and urgency of care. And so we have to tread carefully and really take advantage of all of the treatment options available, use the evidence we have, but also be thoughtful about how to adapt to the current situation that we're in.
That's a really great point. And I think I'll come back to that. I'm just going to put a pin into that piece around kind of the adaptations and thinking about our current context. So that's a really, really critical piece. And I think we could have a more fulsome dialogue about that specific topic in a couple of minutes. But I want to loop back to the piece around kind of patient-directed goals. And as all of you have mentioned so far, kind of the importance of changing some of this inflexibility that seems kind of inherent in prescribing and in the system in general. And so I'm wondering, I'm just thinking about our audience as well, and how this actually looks in practice. So we talk about, rigidity in prescribing and, the system that's been set up that kind of goes against flexibility. But what does it look like in practice? Maybe there are some specific examples folks could provide, and how you've actually incorporated flexibility into the care of your patients. I think that might be really helpful for people to kind of take what we're saying and kind of understand what it looks like in real life.
So I can jump in with an example. Obviously, I'll change a few details around to protect patient identity, confidentiality. But so, for example, with a patient that you might have who is, say, what we call like clinically stable, housing is in a good place, relationships are in a good place, mental health is in a good place, and they're struggling with opioid use disorder. I've had patients in that situation where we've jumped to carry sooner than maybe would have been considered optimal in the past, in service of making the plans more pragmatic for that patient. So the situation that I'm thinking of is a patient who had the patient was very worried about losing their job because of the stigma of showing up to a pharmacy every day for their medication, and they were worried about being seen picking up their medication. And so for that patient, we did everything we could to ensure safety and stability and safe storage and all these other things that we always consider when prescribing OAT, but we jumped to providing take-home doses a lot sooner, because the reality was this patient wouldn't be comfortable engaging with this kind of care without that measure of protection from the adverse effects of stigma. So that was a situation where I was being more flexible maybe than I might have in the past under a different context, like Dr. Hirsch mentioned.
Great, thank you. That's really helpful.
I think flexibility in my practice comes in on a few different levels. One is in the choice of which medication we want to give. So finding out if the patient, what their goals are really. Are they planning to stop using? Are they planning to keep using? If they're planning to keep using, then that there's some medications that impact their ability to feel high when they're using, and so that might impact which one you choose, and yeah, their ability to go to the pharmacy every day or not. It impacts how we prescribe the medication. If they're homeless or if they have a safe place to keep their meds, some people are too chaotic to be able to present to a pharmacy every day, but also don't have a safe place to keep medication or would be vulnerable to other people taking their meds. So can you find a pharmacy that will deliver to them? And also on the level of just working with a model that is inherently punitive, how can we figure out just ways to allow our patients to be honest with us, and to really focus on building that relationship, so that they feel that they can keep coming to us anytime they fall down, anytime they relapse, if they've missed their meds for a few days, things like that, and really trying to advocate for more rapid inductions and for doses that match more our patients' needs in the context of having way higher tolerance than they used to. I'll pass it on to someone else.
I think to me, it's that retention piece as well, but matching not this medication actually related to OAT to other medications, like just overall for the retention part and also to the stigma part that Trish had just mentioned, because sometimes we have to meet individuals at where they are in terms of life. So really honing down to that and having that conversation piece with every team, including the patient.
I'll also say, I think that to that point about flexibility and adaptations, I think that there are lots of fixed beliefs and biases around our medications, some held by us, some held by the public as a whole, some held by our patients, and some. I spend a lot of time in my clinical encounters trying to call those out, identify and talk about them, whether they're my own biases or beliefs or preconceived notions, whether they're those of our patients or whether they're those that have been kind of floated from elsewhere, to really identify some of those ideas or the notions that aren't necessarily grounded in anything specific, and really talk about them with patients and talk about the specific characteristics or goals or traditional uses of the medications that I perceive may not necessarily be the same as what the patient perceives or is looking for, and so not to get too stuck in doing things the way that I feel like they should be done or they've always been done, but really again listening to patient goals, talking about the medication characteristics, and coming up with a tailored treatment plan for what it is that they're trying to achieve, and that may we're seeing lots more non-traditional prescribing, I'll say, these days. And I'm not talking about safe for supply or anything like that necessarily, but just people who are being more flexible or open-minded in their goals with these medications, depending on what a patient's individual experience is and what they're looking for. And I think that we want to continue to try and inform those decisions with evidence as best possible, but also just listening to the patient, trying to put those biases aside on both ends of the table, and just talking about it is always critical.
I'll just add quickly too, to build on what Paxton was saying about, just shifting some of these biases that have been held for a long time, but also some of the structures that have been kind of maintained for a long time. And so I think in terms of how clinics are set up, so not even just the prescribing, but all the pieces around care, like how often are people expected to come in for their appointments, how frequent are urine drug tests being done, and for what purpose. Those are all things we can look at in our practice in an interdisciplinary sense too, and just consider what the rationale is behind all those pieces that do ask a lot of people. So even for folks who are maybe still going to be going to the pharmacy frequently, what are some other ways we can make this care easier for them and feel different? Because I think how it feels contributes a lot to the stigma people feel. And we just want people to keep coming back to see us, and we want them to tell their community that, OUD care can feel okay and it can meet their needs, because we really want, people to be retained, and we want more people to access good care.
So many good points. Really appreciate all of you sharing your expertise, and I think this piece around, what's really resonating for me and hearing all of your comments is really around taking a step back and thinking through, what people need and talking with them and finding out like what are their goals, and also challenging and thinking about what our own beliefs and biases are. I think that's, it sounds pretty straightforward, but I think actually is a lot of work to really understand some of the preconceived notions we have, both as Paxton mentioned about the medications themselves, but also about people and what their goals might be and what our assumptions might be. I also really appreciate what people have said around the expectations of care and what are realistic, and what things should continue, or what's most appropriate for a given person in front of you, rather than kind of a strategy that's just applied to everyone. So maybe, yeah.
If I may add, just for the benefit of people watching, one thing that we didn't bring up is I think a lot of us have a fear of being flexible because of the system we work in. It's not just up to us, it's up to the people that set out the protocols, and we don't, we worry about being audited and so on. But just to reassure people, so many of my colleagues have been audited in the last 2 years because of our change in practice. And in my experience and the experience of my colleagues, if you can explain why you have been flexible, if you can explain why you made the choices you did and show that you really weighed the risks and benefits for your patients, ultimately nobody had any problems. Like, the people were understanding, and they just wanted to know that we had a rationale. So flexibility also is possible nowadays, which is nice.
Thank you for that. Yeah, that's a really important point. And I guess, I'm seeing the time, I'm conscious we have another kind of key question we want to get to, and also allow some time for audience questions. And you nicely set me up for this next one, Dr. Hirsch, with your point about kind of the outdated model of treatment we're operating within, and kind of our urgency in terms of care, and the changing context within which all of you find yourselves working in. So, it does feel like the health service delivery landscape has really changed in the past couple of years, both during and following the pandemic. And I think, in addition to that, we are in the midst of an ongoing and escalating overdose crisis that certainly, impacts how we deliver care and that urgency piece, as you mentioned. So I'm wondering, what your experiences have been in the last couple of years. And I'm curious, both the pandemic and, this is a huge question. So maybe just in terms of flexibility, specifically thinking about how the pandemic, how there may be certain approaches or practices that emerged during the last couple of years that you're finding really effective, and maybe some others that you've stopped doing because, in wanting to be a bit more flexible. So maybe I'll start with if someone would like to contribute a thought first on this.
Yeah, I would say that I think the pandemic forced a certain amount of flexibility on all of us as prescribers. And at least in my practice, I don't think it has become the disaster that some people feared it would be, to really to become more flexible. I think it's actually improved retention, or at least that's what I've seen in my own practice. We started doing a lot more phone follow-ups in the places that I work. We started giving carries sooner. We started, really just doing what we could to limit people's exposure to, frankly, each other in the pandemic. There was more delivery of medications by our pharmacist colleagues. And honestly, I think that's all been for the better. The patients that I've spoken to about it have said that they really appreciated that level of autonomy. And I think, as long as you're starting from a place of good rapport with the patient, and you've earned the patient's trust, and you talk openly about things like diversion, about things like the constraints on their actual day-to-day lives that make some aspects of this care challenging. For the most part, there's a way through or around the things that spring up with that added flexibility. So I think the pandemic was challenging in a lot of ways, but I think it has been, continues to be challenging in a lot of ways. But that increased flexibility has actually, I feel, been beneficial.
Great, thank you. And I really appreciate some of the specific examples, like the kind of phone follow-ups, or maybe reducing follow-ups where possible. providing carries sooner, and kind of the delivery of medications, which we know, some of these approaches may not work in all settings, may be more challenging for folks who are living in more rural and remote settings, potentially. Anything else anyone would like to comment on in terms of kind of the last few years and how that's kind of changed your practice?
I think the flexibility for me in pharmacy is like to transfer prescriptions to ensure that the continuity is there. Use of emergency for sure. And then recently a lot more with new scope and extending some of the opioid agonist therapy just to help in terms of keeping individual goals at home, even with the different carriers of if like snow, for example, this week, if they miss their appointment. So that's been really helpful to continue on to get to the goals.
I think for flexibility for me, there's been a huge increase in the toolkit that I have to treat people with injectables and fentanyl patches. And so especially for people who, have not succeeded with or who have just tried multiple treatments multiple times, and it can often help with motivation to be able to offer something different. And so that's been fantastic. Safe supply is a whole discussion for another time, but that's a very new part of our practice. And then I think a big difference is also people's tolerance. We're dealing with like a whole other level of tolerance. So more flexibility in prescribing is required.
I don't have much to add to what the other panelists already said, other than it's been a really challenging time a challenging time for everyone, a challenging time to be a physician, and a challenging time to be working in addictions. Certainly, every week I go to work, I feel ill-equipped to do my job, and I feel more and more confused than the week before. But the one takeaway that has been productive, I can't even call it positive, but it's taken overlapping crises of this magnitude to kind of jolt us out of some of the really dogmatic practices that we've been following for many years, and that likely never really were particularly well based in evidence or patient-centered, but we just didn't focus on that. And so the renewed focus on trying to build a system that's more evidence-based and patient-centered and flexible, I think is only a positive thing. But the fact that it's taken us, it's taken this degree of crisis to drive that, and how quickly the landscape shifting under our feet is just making it incredibly challenging to do this work these days. And I just applaud all the panelists and all the audience members for staying with this and being here. It's a hard time, and I appreciate everything everyone's doing.
Thank you so much, Paxton, for your candor. And I think for this bit of a summary, I think of what we've just been talking about, it's both been an opportunity and a challenge this last couple of years. So an opportunity where we have maybe expanded our toolkit in terms of the types of medications we can offer, but also expanded opportunities to be flexible, like for pharmacists being able to extend scripts and things, but also such an unfortunate turn of events that has kind of brought this opportunity about. So really helpful to, I think, reflect on that as well. And really appreciate you mentioning that, because it is such an important kind of part of what everyone brings to their work day to day, and just it continues to be an extreme challenge. So really appreciate you mentioning that. Seeing the time, I do want to make sure we have enough time for some audience questions. So we'll turn it over to the audience now. Please feel free to put your question in the chat, and then we can open it up to either a specific panelist. Please let us know if you'd like to direct your question at someone specifically, or just in general to the panel, and we'll do our best to accommodate the questions that come through. So maybe while people are thinking and typing and coming up with some ideas, I guess I'm wondering, in light of what we've just talked about in terms of both the importance of flexibility, some new opportunities to kind of feel, empowered to do some things that are a bit outside these more traditional and punitive models. I'm wondering in terms of both for the panelists and others to think about, what advice would you have for other clinicians, potentially people who might be new to this work, in terms of how to do this. So obviously you all bring a ton of experience and, lots of trial and, I've been able to try lots of different things out, and I guess I'm just curious for some folks on the call that might be new to practice, addiction practice, what advice you might have on how to incorporate this flexibility kind of as a takeaway after this call.
I can start. I would say listen to your patients. It sounds self-evident, but just to listen to patients and again, be open-minded and talk with your colleagues. There's no easy answers these days. And I spend a lot of time just throwing around ideas with my colleagues. And for those of you who are looking for someone else to talk to, we always have the 24/7 line or the race line. I work on both of those, and I will tell you, half of the phone calls I get, there's no right answer. There's no specific advice I can provide. Somebody is just out there looking with a challenging situation, just wants to talk it through with somebody else and just throw some ideas around. Because nothing's easy these days. So knowing that you have that support from your colleagues or from us at the 24/7 or race if ever needed, I'm always happy to chat about cases.
Just to build on that too, there's an opportunity for a lot of creativity and interdisciplinary care, especially in areas that have less resources. And so thinking about ways there can be collateral information provided and ways that can get around things that might not be written into guidelines yet, but ways you can sort of get information and again, provide rationales for decisions you made.
That's what I was going to say too. Just a bit of pragmatic advice is just document your thinking, document your reasoning, document that shared decision making that you've gone through with your patient so that it's clear from your notes. If you're doing something that's a little bit off the beaten path, but it's what you truly think is in the best interest of your patient's health and safety and meeting their wellness goals, just document that so that it's clear for anybody else coming afterwards wondering why the heck you did the thing you did. Here's the reason why. Here are the factors we considered. Here's why I thought it was riskier to do anything else. So just document.
Great, thank you so much. So there's a couple of questions in the chat I'll move to. The first one is, given the precarity of access to housing for those who may be receiving OAT and understanding that housing and keeping take-homes in a safe space is really important, is there anything that might help prescribers bridge potential gaps in connection with social services to help advocate for carries or to maintain carries if someone loses their housing?
I can speak to situations that I've worked with that where a large proportion of my patients are not housed, and I would say the aim of safe storage is safe storage. So when you're documenting, when you're thinking about what that means, who are you keeping it safe from, and what does safe really mean? So some patients have a locked cabinet at a friend's place that they can use. If that is safer than the alternative of not providing them with care, document that and go for it, I would think, if it seems like the right and the safest thing going forward. I do things like document whether there are children in their lives or other vulnerable adults in their lives who could accidentally get their hands on the medication. It's always tricky when we're talking about patients who are not housed. I think, well, again, like Dr. Hirsch said, context is a big piece of this, weighing all of these considerations against what is the risk of not engaging this patient in what could be life-saving care in the context of a drug poisoning crisis. So safe storage, I'd encourage you to think about what does safety mean and how can we meet that and how can we get creative about meeting that.
Great, thank you. That a really great answer. And I think something, the point you raised around weighing all these different considerations as well against the risk of what inaction or, not providing someone with that treatment could look like and the real impacts of that. I'll move to the next question, which is based on your experience as healthcare providers to people who use opioids. Have people who used opioids described pros and cons to healthcare through virtual means? So the idea that we're doing a lot more virtual care. Have you heard from the actual folks who are using those services, what it's been like for them? And what was your experience as a provider through virtual clinics?
I was really surprised at how well virtual care could work. I was expecting that I wouldn't be able to, especially working with people with so much trauma, establish like deep connections. But yeah, I think it worked very well. And I think people really appreciate being, especially since so often when they come in, it's just to renew a medication or change a dose. And they often have to do so many more appointments than the average person with a chronic illness. So I think virtual care is a great addition to our toolkit. In the context of my patients, it's just often limited by the fact that people often don't have phones. And this sort of answers both this question and the previous one. I have loved having more interaction and relationships with the pharmacists in my community. I feel like they have become such great allies in our care, doing so much more delivery work, even to like shelters and things like that. And so really taking advantage of them and even saying, the patient doesn't have a phone when they come in, asking them to give us a call and just let us know how the patients are doing or if they need a change in dose, things like that. Pharmacists have been great about working with us in that way.
I would echo that, Elena. I had misgivings or concerns when we were going into this, and I wasn't sure how it was going to pan out, and I wasn't confident in my ability to develop those relationships and to practice safely. And in retrospect, I think those were all kind of silly. Like, of course, it can be an effective tool, and it's been a really satisfying way to provide care, especially for patients, like you said, who are who have to travel a long ways or just coming in for a refill, or who find coming to the clinic to be a really stressful or triggering environment. So it's been again, it's one of those dogmatic practices, I think, that hopefully our complete rejection of telemedicine as a viable way of practicing addiction medicine, I think is gone by the wayside, and I hope to see more and more information on how to integrate that into our practice. I can say we do have we're exploring some data, and this is really specific to this question in Vancouver at the BC CSU. So this is timely, and I can say that just some of the preliminary results we're looking at was that it was widely adopted in the context of the pandemic, as you would expect, and generally speaking, most people were at least as satisfied, if not more satisfied, getting some of the care through telemedicine than having to come in every time, which I think really reflects my clinical experiences.
Great, thank you, Paxton, and thanks, Alana, for your thoughts as well on this. I'm conscious of the time, so just a note that as we near 1 o'clock, most of the panelists will continue to be available for the next 5 or 10 minutes. I see another question in the chat, at least one other that we can probably get to. For those of you who need to sign off, thank you so much for joining us, and a big thank you to our presenter and panelists. Of course, we really appreciate you all taking the time to share your experiences, practical strategies, and also hearing the passion that you bring to this important work. We really appreciate your feedback. People will have seen some polling questions. Please take a moment to answer those. And as I mentioned earlier, we're also sending out a post-session questionnaire after the session by email. If you complete both the pre and post questionnaires, we'll be doing draws for 2 $50 gift cards. So please fill those out if you have a moment. And so I'm sure people will start to trickle out a little bit. And I see that Lizzie's just put the post-event survey in the chat as well. So if you want to just click that link, that's probably the quickest way to get that and get entered into the draw. So maybe we will, since it's one right on the nose, we'll take one more question that I saw pop up in the chat and then see how our time is going. So Heather Taylor writes, do you have any boundaries or limits and what are they in terms of prescribing opioid agonist treatment? And I think she means and substance use and substance use in particular. So working with people who use substances, maybe this, I'm not sure if I'm getting this correct, but yeah, I think it's probably prescribing opioid agonist treatment for people who are continuing to use substances.
I wonder if she means safe supply. I think she may mean
Yeah,
safe supply
maybe
from-
safer alternatives or something.
Okay.
Yeah.
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 Oh, safe supply. Yeah. Great. It's a bit of a loaded question, and we may not have time to get fully into this. But I think, you know, we've talked about some flexibilities and ways to be more flexible. And so perhaps people could just, you know, in a short bit, talk a little bit about what that can look like with a broader range of options in terms of medications.
You know, I think the options are all options, and the intent of safer supply is to help make the patient's life safer and help them meet their wellness goals with regards to substance use, whatever those are, and whether or not those are the goals I think I would have in their situation. So in terms of what the boundaries are, we're obviously all bound by our colleges and the different obligations that we have towards governing bodies, et cetera, but whether or not to prescribe safe supply or safer supply, I think really depends, again, individually on your patient and your patient's circumstance and what role that safer supply is going to play for them to help them meet their goals. If OAT meets that better in a shared decision-making capacity, we all agree that meets it better, then we go OAT route. I do prescribe safer supply, and I would say that if prescribing that actually helps them meet their goals better, then we go in that direction. And we talk about the risks and benefits of each, because there is no safe supply and there is no safe route forward. There's just making things safer and helping people be more well.
Thanks, Trish. Yeah, I think that's so important, and thinking about both being goal-oriented as defined by the person in front of you, and also the piece around informed decision-making, I think is so critical. So thank you for raising that.
The only thing I would not even add, but echo when Trish's statement is, you know, we try and center myself around the guidelines and guidance documents that we have, because they're there for a reason, and it's not about the colleges so much as that's, you know, at least some consensus that we've achieved. But I would say there are very few, if any, absolutes these days. I would say almost no absolutes. You know, that in every situation you're weighing the risks and benefits for an individual patient. And making decisions accordingly, and sometimes we do tend to deviate quite significantly from what is, you know, what is classically described in our guidance. And as long as that's well thought out and carefully documented, then I think that there are very few absolutes in the current era.
Great. I'm not seeing any other notes in the chat. I do want to just reiterate some of the points around the advice that people would have for newer clinicians, and just end, I guess, on that, because I think those were some important points, and we went right into the next question. But really being open-minded, listening to your patients, and I think we talked a lot about, or the panelists talked a lot about, the importance of shared decision-making, goal setting that's patient-oriented, as well as what you just said, Paxton, around the importance of, you know, clinical guidance and clinical guidelines and best practices as we know them, but also taking really an individual approach. And that also people have said there's lots of ambiguity in this work. So the importance of talking to your colleagues, getting advice, troubleshooting ideas, and also just to reiterate some of the resources that are available to folks in BC, including the 24/7 line and the race line, and the importance of documenting everything, including some of the process around shared decision-making and some of the rationale for some of the decisions you're making, regardless of what type of practice setting you're in. So with that, I'm not seeing any other questions in the chat. I'm wondering if each panelist would like to just take 5 seconds, and we can close out the panel. if there's just one like imparting thought people would like folks to leave with, I'll just give you an opportunity if you're interested to just take 5 or 10 seconds, and then we'll close out today's session.
I was just going to say, keep on the conversations and share and learn from each other, because there's just a lot of different models out there.
I think it would be amiss if I didn't sort of mention the newer practice in BC of registered nurse and registered psychiatric nurse prescribing being a really an emerging way that we can improve flexibility. So, you know, if anyone is a nurse or sort of can support that being implemented in their area, that can be a huge piece in increasing flexibility. And yeah, when we offer flexibility, we communicate trust and respect with our patients, and you know that can go a long way in just improving care and improving our experience as clinicians too. So thanks for your work.
Great. Well, thank you all so much for joining us. Again, a big thank you to Eugenia and our panelists for their time and for sharing all of their expertise and experiences and some of the real life challenges that you're all facing in your day-to-day work. Again, please fill out the post-session questionnaire. It helps us improve future sessions. And again, just a big thank you for joining us.